Hi, my name is Tabitha Dorsey. I am an ER nurse, been an ER nurse for about 4.5 years. New flight nurse, very exciting. And this is my educational presentation for Critical Care Transport Academy class of 2023 Neurology Module Care of Neuro Emergencies. I have chose to talk about, dig into a little bit brain herniation, kind of what they're about, causes, symptoms, care of these patients pre-hospital, whether it's like true pre-hospital or interfacility transfers of these people who herniate going from one hospital to the next. So I have seen this one time in my career, actually seen it at bedside with a neurosurgeon standing right there. Trauma patient, I believe it was a pretty severe MBC. Patient came in as a priority 1 trauma. Patient was not RSI'd in the field. Semi-talking when she first came in. We get her in the trauma bay and her GCS starts to decline. She starts to get more lethargic, more altered. And we were in the process getting ready to RSI her and oral intubation, and it's like a switch flipped. She had all the classic symptoms of herniation, that Cushing's reflex that they talk about, systolic hypertension, bradycardia. She began posturing, and we RSI'd her immediately, and neurosurgery took her straight to the OR. Kind of the down and dirty behind brain herniation is, the brain sits in your cranial cavity, and the brain and your CSF are the only things that should be in there, and they sit in a specific position and they like it just the way it is. So when you get things like people who have masses in their brain, or you have a traumatic brain injury to where it causes blood to pool in the brain, you have people with abscesses, and you have these pockets of pus that form from infections in the brain. But anything that forms in the brain that repositions it can cause a herniation. You get hematomas or hemorrhagic strokes, things like that kind of push the brain to one side or the other, reposition it, things like that. If you have an open skull fracture or a depressed skull fracture, or even a surgical opening from a craniotomy, the brain can herniate out of those openings. They can herniate in, they can herniate down, they'll herniate down into your brain stem through your foramen magnum, and it's absolutely something that needs to be monitored, and that providers in the field need to know how to watch for these kinds of symptoms, because they are an absolute emergency that require neurosurgery and an OR immediately. So you've got these patients in the field, and you suspect that they have a traumatic brain injury, or maybe you're transporting a brain bleed, as we call it, or a hemorrhagic stroke from one facility to the other, and you're monitoring vital signs, and you're watching the patients, and you're watching their neurostatus, and they start to display these symptoms. They get the systolic hypertension, and their pulse pressure rises. They get irregular respirations. They become bradycardic. They start that posturing, or maybe even seizing, or maybe they're alert and oriented and they just become more lethargic. They start complaining of a headache. Their GCS plummets. They become altered. If your patient is not already intubated at this time, this is probably a good time to do it. Definitely RSI these patients. You want to do interventions that are going to keep their intracranial pressure down. You want good sedation, definitely paralytics on board, good pain control, because pain can cause their intracranial pressure to rise. You want to do oral intubation on these patients, not nasal intubation, because you don't want any gagging or anything like that. No gagging, no coughing. Head of the bed 30 degrees. You just want to make sure that you're keeping these patients very, very comfortable. This will keep their intracranial pressure down. And while in transport, when they get the systolic hypertension, you do want to keep them about 160, 180 on their systolic blood pressure, but you don't want to drop them too low because they still need to perfuse their brain. So you don't want to make them normotensive. You don't want their systolic pressure in the 120s or 130s. You want their pressure to be a little on the higher side, 160s, 180s. Definitely don't want them in the 200s, but you have to maintain the perfusion to their brain. The outcome for these patients is usually when they get to this point and they get to the stage of herniation, and when this happens, their outcome is usually pretty grim. They usually, suffer brain death, or usually herniation can cause a respiratory or cardiac arrest that they usually can't survive unless they're either in or on their way to an OR immediately for craniotomy or craniectomy. But these patients require very constant monitoring. You have to be able to know these symptoms and see these symptoms and be able to watch for them. And if you do see that they're happening, you need to, whether you're getting on your radio, getting on your phone, and alerting the facility that you're coming to and saying, hey, this patient is doing this. I think they may be herniating. If you want to get your neurologist on board, your neurosurgeon on board, and have the OR ready when we get there with this patient. This patient is going to need to go to the OR immediately. Hypertonic fluids are helpful in these patients. Whether it's mannitol, is I know a lot of field providers and agencies don't carry mannitol, but if you do have it, definitely use it. Learn how to use it, learn your doses, learn how to administer it, and things like that. And when you get to these facilities, talk to your neurosurgeons and say, hey, when we get these patients in the field, what do you want us to do? What would be your recommendations for care for these patients in the field? And they're definitely going to talk to you and definitely going to give you some recommendations on what to do with these patients, because the faster you get them care and the faster you get them to a stroke center or a level 1 trauma center, the better. I hope this was helpful. And thank you very much for your time.